Good morning.
Good morning.
How are you?
I'm great and yourself.
I'm here.
Ah,
Eyes here, eyes here. How's it going?
it's going pretty good. How
All
about
right,
you?
all right, all right, all right. I know y'all received y'all stuff in the midnight hours. Okay. I took a nap and I woke up. It was about 9:30. I said, "Oh, I still have work to do."
I was surprised. I'm like, I thought she'd be in bed by now.
What'd you say? I'm sorry.
I said, I was surprised. I was like, I thought she'd be in bed by now.
I had already been in bed.
Oh, okay.
Woke up like, I know there is something else I'm supposed to be doing. And that was it. Oh goodness, goodness. All right, all right. Well, let's get this party started. Welcome everybody. Welcome to our Saturday morning tea where we discuss health information, news, education, certification tips, uh taking naps during the evening. And making sure you finish your work as well as entrepreneurship. Really, the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I am loving this mic for real. I connected the new mic. I'm loving it. I'm loving it.
Okay.
Okay, all
It
right.
sounds good.
I'm real far away and you can still hear me. I said, okay,
Uh-huh.
look at God. Okay. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance in education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? I swear we talk about being marketable, uh, being certified, being a medical coder. I think we talk about that over and over and over again. But do you know what it takes? Well, before I introduce my co host, even though we have been chatting away, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey, okay. If you're interested in getting more information about the 5 steps to become a certified marketable medical coder, check out the video description for the link. So, joining me today is my partner in success. I love that. My co host, Mr. Jesse, the registered trademark. Put some respect on his name. Yeah, let me just say this before I go any further. The respect factor, you have no idea. You have no idea. What I witnessed in our live meeting with the movie premiere, the respect factor was just flowing. It was just dripping, y'all. It's just dripping. He exudes all of the stuff that y'all see is real. It's real, real. He comes a buck. So let me give you the intro again. So put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been a nurse for a very long time. In 2014, I transitioned away from the bedside into medical coding. And during the pandemic in 2020, I created a company called the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is that going for you?
It's going well.
And isn't it a wonderful world?
Yeah.
Oh, what a wonderful world.
Just last night, I found out that one of my students who went through my course and got certified got a CDI job offer.
Yes. Don't you love it? There is nothing more gratifying, if you will, to see the success of others that you've that have crossed your path. I love that. I absolutely love that. So um and I like that they come back and share. You know what I'm saying? And tell you, hey, let me tell you, da 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 da. I think that is so great. Um yeah, yeah. I have a student that he was was he my yeah, I think he was my first male student. And I'm like, what you doing here? You know, and he was he's an African American male. And so I was shocked to see, him in my class, but he did his thing, he jammed. And then, I see him, he's in a local band and I see him all the time. And I have two students that whenever they see me, they call me Teach. And so they'd be like, teach, teach. And he'd be like, teach, da 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 da, or check me out on Facebook or see that, and you can see all the different things he's done in his career, not only in health information. He went on and got his degree. He's doing it. I think he recently got married. Like all of the things. It's just wonderful. And that the people, at least the ones, most of them that I come across, I mean, they become like family. You see them all the time, you talk to them, they share the information. It's a great thing. And so, yeah, it gives it's a warm and fuzzy feeling when you hear back from those that you taught and seeing the difference that was made just in their decision to jump into this field and how they have even amazed themselves on what they could do and what they have done in the field. So it's I love it. I love it.
And
So
before we go on, I also
yes, sir.
want to give a shout out to one of our uh, one of our Saturday morning tea sippers who listens from Louisiana. I had a consultation last night with a nurse named Shayla who lives in Louisiana, and she says that she watches us all the time. And what
Yes.
was funny was she loved how I always talk about gatekeeping, and it's true.
Oh, wait. Now that you mentioned that, I got a comment on one of our posts, and they were like, it was one of the shorts that I did, and the comment was like, I think this was supposed to be funny, even though I think we was laughing about something. She's like, but I learned something. But could you expound on the compassionate sacrifice?
Oh,
And I said I was gonna bring that up and let you expound on the compassionate sacrifice.
compassion and sacrifice has stuck with me. It's got to be about a year now.
It has.
Got to be. So there was an article by by the wonderful physicians at the American Medical Association,
Yes.
and they were talking about the burden under which they have to work.
Undue burden.
Yeah.
Put it.
And this was really talking about, they were really trying to block nurse practitioners. So in the article that this physician was talking about, he talked about the compassionate sacrifice that doctors make, and I have found that to be hilarious. It has stuck with me. I think it is so funny because everybody in healthcare is compassionate, and all I can say is the reason why it's also funny to me is because when I'm sending these queries, they don't seem to be too compassionate. And when I ask them to clarify their diseases, they don't seem to be too compassionate. So this compassionate sacrifice is something that I don't see
Oh.
on my day to day, but it has just been funny to me since then.
That tickled me. So when I got up and was putting everything together for this morning, and I went and I was like, "Oh, I got a comment," and I read it. I hollered over here. When I tell you I hollered, I was hollering.
So long story short, after all that, you'll have to ask them to expand about upon their compassionate sacrifice because it's just funny for me over here in Philly.
Right, right. Oh my goodness. Let's see who we got in the house. Well, welcome Shayla
Awesome.
for watching. Good morning, Tanika. Good morning. Good morning. Good morning to our on the street correspondent, the crafty coder. Good morning. Good morning. Good morning, Miss Carolyn. Everybody's laughing.
Mhm. Hey, Renita.
Good morning, Renita. Good morning. Good morning. All right. All right. Our gang is in the house. We all in the house. All right. All right. So, let's see. Let's see. Before we jump in, for those who may be new and watching us or even watching the replay, let me remind you that you can join in and add to the conversation, even after the fact, because I do check comments. um, don't be shy. Your opinion matters and is welcomed here. We love to see what your thoughts are. Most of y'all should be on Comic View quietly, but we love to see the thoughts and opinions that our viewers have. So please use the chat. Use the chat and let us know what you think about the information that we're providing. Again, we're providing information and we're giving kind of our uh, initial feedback on the topics, but we really are interested in what your thoughts are, um, coming from your perspective in health information. And if you have a question, please type Q first so that we know it is a question and we don't miss it. So, for those of you who are just joining us or watching the replay, uh, today we are talking about the IPPS 2025 Housing Codes Shakeup Healthcare Data. But first, let me get into my church. This was the other thing I didn't do. Let's get into our church announcements, shall we? Shall we? I don't have a fan because I gave it to you. So I didn't make up a new one. That's the other thing I didn't do this week. I'm like,
Oh,
I don't have
Lord.
a fan. Where is Martin Luther the King Jr.? There you go. We done switch roles.
Yes.
I was like, I'm fanless. I'm fanless. So maybe I just go into the double clap. Yes.
There you go.
Crazy, crazy. All right, all right. Let me turn this down. Oh, that was real low. Okay. There's the usher fingers. Yes, yes, yes.
Mhm.
So, my church announcement today is a little personal. Um, I watch, I watch, I have a couple of creators that I watch, and they have what's called Dream Talk. And I love when they do Dream Talk. And Dream Talk is kind of when they just really dreaming out loud. They just talking about the things that they want to do or things they want to experience. They don't even know. And oftentimes the dream talk is way bigger than anything that they could ever think or that they could possibly do. But the beauty of it is, as I've watched them and I've followed these folks for years, those dreams come to pass, and it's a beautiful thing to see when that happens, and how just speaking it into existence, and putting in the work and the follow through and just all of the things. It's a beautiful thing. I call him. I always when I comment on him, I'm like, you are a walking masterclass to me. I see it every time. You say you're gonna do something or you try and he just trying. Like, I don't even know how to do this, but I want to do it, and I just try to figure out. And I kind of do the same thing in my life on different occasions, and it's like, well, I know just like when we were live, I was like, I know this can happen. I know we can put this together. I don't know how, what, but I know I need this, that, and a third. Go get it, put it together, connect it, and say a prayer that it all works. So they have this thing called Dream Talk. Well, anyway, so we're gonna have our little session of Dream Talk for today. so so um I don't know if you know, and I have a huge whiteboard in my office, and I write all kinds of things on it. And one of the things I have is be open to your dreams coming true a different way. So even though you may dream it and you think maybe it'll happen this way, you'll be surprised things happen in a different way. Well, I've been talking about writing a book for several years. I've reached out to some folks to see if they want to partner, and yeah, that book hasn't come out yet. I actually have put the finishing touches on my original book, which I'm still going to do. Um, um, when the time permits itself. So I have like two books in my head that I just want to kind of throw together. But over the when I got back home this week on Thursday, we had a group have a gathering to commemorate our book that we wrote. So I am in a poetry book. I wrote some poems. It's Mindful Poetry Moments. And I have 2 poems that were submitted and placed into the book. And I was just over the moon. I invited my husband, like, you want to go? I didn't tell him where we were going. You know, I'm good for that. I took him to Vegas one time and he didn't even know where we were going. And he was lightweight upset with me because he didn't know, like, well, what should I pack? I was like, just pack some stuff and bring your camera. That's all you need to do. But so he was like, can I bring my camera this time? I said, sure, bring your camera. So he came down, he was taking all kinds of pictures. He'd be in his element when he's doing photography. But anyway, so I was so excited about, you know, it's a for real book. It got the little ISBN number. I mean, it's real. It ain't something that, you know, we glued together. And there are children in the book. So it was great. So we actually had like the poetry reading. We got together. People were on Zoom. I was peeping out how he connected. It was a whole thing on the tech side. I done took pictures of his, you know, I'm always watching people set up. I was like, what? Wait a minute, hold up. So I done took pictures. I was like, oh, that's how we gonna do that. um, but yeah, so I am an author and poet. And so I just want to share that with you all. Yay. Thank
That's
you. Thank you.
congratulations. That's
Thank you.
huge.
Thank you. Thank you. So yeah, let me show. Uh, thank you, everybody. Thank you. So, um, yeah, that was my thing. So I was all excited. I was like, oh, and I think, you know, they was like, well, we sent the books to everybody. And I was like, I don't even remember getting a book. But now that we talked about it, I was like, I think I did. But I was like, who sent me this book? I didn't read it. I didn't remember. So what we did, they do it in April. So if anybody is interested, because these people, the authors are all over the world. If anybody is interested, let me know. I can connect you. In April, we get together once a week, and it is, they select poems. They have a facilitator. We get on a Zoom for about an hour. We read the poem, we talk about the poem, and then they give us a prompt. Look, we become AI. They give us a prompt. And in 10 minutes, you have to kind of write a poem or write something about using the prompt that they gave. And then if you want to edit it, they have a whole editing session in May. But they really just want what your raw feelings are right there in the moment in those 10 minutes. So I did 3 of them. But I didn't realize the 3rd one was on the opposite page of one of the ones I submitted, because I was like, I know I did another one where I didn't, so I didn't submit that one. But it was fun. It was an experience to do, and like I said, it's open to anybody. It doesn't cost you anything to be a part of either coming to the Zooms or even being in the book. So if anybody is interested, let me know. I can definitely connect you um, um, to this project. Yeah, and it's fun. Good morning. Good morning. So that was my church announcement.
Good morning, Raquel.
Good morning. Yes, I still owe you a phone call. I know. All right, y'all. All right, y'all. Mr. Jesse, do you have any church announcements for the good of the people?
The only church announcement I have is just we talk about it all the time, but my church announcement is for everybody who's watching or will watch, go after what you want.
Mm,
Like you just have no idea. We talk ourselves out of our own success. And really and truly, I had a cousin who was all in the whole like Mary Kay Amway type thing
mhm.
years ago, and she had this um voicemail recording. This was back when people had
The actual
actual,
machines, right?
yeah. And so her message was, I mean, she sounded all bright and bubbly. The only barrier to success is you.
Mm,
And I mean, I used to cackle, but it's the truth when you really
it's the
think about
truth.
it.
It is the truth.
And really quickly, like this week, everybody knows like I left my job last week. So this week I was like, I've got to start calling these practices to get some, drum up some business. So you can find the practices very easily doing a Google search, but I couldn't find an email address. So I'm like, okay, so I just started cold calling. And what I found is that the people were very nice. Like now I never got to talk to any office manager, but I got something more important. I got their email address because their email address wasn't on the website and it wasn't like a generic info at what blah blah blah.
Mhm.
So they would, so I had my whole spiel and I'm like, can I speak to the office manager? Blah, 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 blah. So some of them were like, well, you could leave it. Well, doctor, you could leave a message. So I said, well, so if they said that, I would say, well, could you provide me with an email address? And they were like, oh, okay, sure. Or some of them would say, they're not available, but I can give you their email address. And then
Mhm.
they would even, it wouldn't be like, oh, blah, 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 blah. Thank you for calling. They'd be like, okay, read it back so I can to make sure you got it. I mean,
Yeah.
that's great.
Yes.
And it's a positive experience because you just don't know. Like all you have to do is just do it. And
Hmm.
the next step is going to be revealed once you take that step.
Yep.
So
Yep. And I've heard
good.
somebody says, do it afraid. So even though it may scare the bejeebas out of you, just do it anyway. And I always live by the only thing they can do is tell me no, and no won't kill me. I just keep going until I get that yes.
Exactly.
Mhm.
And you just have to have a pretty like because I mean I was playing around with some stuff to say. I mean I'm like you gotta let them know why you calling.
Exactly.
Like you don't just say, well, can I have the address? I mean I had a whole I had some I had two scripts and I was just like, okay, I was just
All
winging
right,
it, whichever
Scripty.
one. Exactly. So now come Monday I got some more people I gotta
Oh,
call.
it's on and popping. Look at that. Look
Mhm.
at that. And it'll be easier because you done already overcome
Exactly.
that initial fear of how do I do this? How do I cold call? That's what's up. I love it. All right. Congratulations. I love it.
Thank you.
And then when when the dollars come rolling in, where the dollars at? Oh.
Mhm.
Where the money reside, where the money
Yep.
reside. All right, all right. Let me get rid of the banner. Okay, so let's get into what we're going to talk about today. Let the tea spilling begin. So, first of all, let's level set a couple things. Let's talk a little bit about social determinants of health. And I know if you are in healthcare, health information, unless you've been under a rock anywhere, even as patients, everybody has talked about social determinants of health all over the world. But these are conditions in which people are born, grow, live, work, and age that affect their health outcomes. These includes factors like education, income, housing, access to healthcare, and your community environment. So as the healthcare industry shifts towards what they like to call value-based care, at least here in the US, and population health management, there's a growing recognition of the importance of the social determinants of health data in providing comprehensive patient care and improving overall health outcomes. Now, I did all of that, or level set all of that, to say that on August 1st, the Centers for Medicare and Medicaid Services, or CMS, issued their fiscal year 2025 Medicare Hospital Inpatient Prospective Payment System. That's what the IPPS stands for. They also did the Long-Term Care Hospital Prospective Payment System, which is PPS. Well, they issued the final rules. The final rule updates Medicare for fee-for-service payment rates and policies for inpatient hospitals for fiscal year 2025. So CMS pays acute care hospitals, with a few exceptions specified in the law, for inpatient stays under the IPPS. CMS will set base payment rates prospectively for inpatient stays based on the patient's diagnosis, the services and treatment provided, and severity of illness. Subject to certain adjustments, a hospital receives a single payment for each case, depending on the payment classification assigned at discharge. The classification system is under IPPS, the Medicare Severity Diagnosis Related Groups, or MSDRGs. I hope you learned that in your coding class. Let me just say that.
Oh,
Shots fired. Pow, pow,
oh,
pow,
yeah.
pow, pow. But anyway.
That was some nasty work. Oh,
Oh my gosh. Okay. I couldn't resist. I was like, wait a minute, hold up. So anyway, so one of the CMS puts together this fact sheet that talks about all of the things that are in the IPPS final rule, and you can find also the final rule in the Federal Register, and it's comprehensive. It's probably 100 or so pages. But remember, before they do the final rule, they have a proposed rule. And so they have a 60-day comment period where people can provide comments. So all of the comments, all of their responses to the comments, all of the things that led up to the final rule is in that larger document that is published in the Federal Register. CMS just does a quick and easy, here are the cliff notes, if you will, of the final rule. So one of the things that is in there are resources for treating patients with inadequate housing. So the IPPS payment is made based on the use of hospital resources in the treatment of an individual's severity of illness, complexity of service, and/or consumption of resources. So generally, a higher severity level designation of a diagnosis code results in a higher payment to reflect the increased hospital revenue use. So they looked at some data. They did a whole data analysis of the impact on resource use generated using claims data, and CMS is finalizing the proposal to change the severity designation of the 7 ICD-10-CM diagnosis codes that describe inadequate housing and housing instability from a non-complication or comorbidity, so a non-CC, to a complication or comorbidity, to a CC, based on the higher average resource cost of cases with these diagnosis codes compared to similar cases without these codes. So this builds on their policy from last year for diagnosis codes describing homelessness. For example, they had unspecified, sheltered, and unsheltered. And the category that these codes all sit under is in the Z codes. Z59 is the category. So this final policy also aligns with the Biden-Harris administration's broader work to recognize the influence of social factors on health and resources, including efforts of the U.S. Interagency Council on Homelessness, which recognizes housing stability as essential to the health and well-being of individuals and families. The finalized policy will more accurately reflect the resource costs associated with each healthcare encounter when hospitals take care of people who have inadequate housing or have housing instability, and will also improve the reliability and validity of the coded data, including in support of efforts to advance health equity. Now, all that mouthpiece to say, or mouthful to say, that the hospital will now receive additional funds for the resources that they use in order to treat patients who also carry a social determinant of health diagnosis code related to homelessness or home insecurity. We've talked about this a lot where, it's like, well, why won't they collect the data? What are the incentives? So here is an additional incentive for folks to begin to collect the data around social determinants of health. But let's think about the significance of the IPP. And Mr. Jesse, you can jump in anytime. IPPS 2025 final rule in recognizing the impact of housing instability on healthcare resources and its role in advancing health equity through the social determinants of health data collection for use. So a couple things. Go ahead.
So I just wanted to jump in because it's almost like, so now the social determinants of health are out. It seems like it's a no brainer, and it's like they should have done this a long time ago.
A long time ago.
And because now that social determinants are a thing and they are a CC, it is amazing how you can connect the dots because everybody knows I was doing inpatient CDI, and I've had patients who were homeless. I've covered patients who were homeless, and you can see how, I mean, logically, how someone being unhoused can affect their ability to care for themselves and receive care.
Mm-hmm.
And you can really see the resource, how resource intensive those
Mm-hmm.
people are, because they're going to be repeat repeat hospital admissions, because if you're on the street, how can you get adequate wound care? If you're on the street, how can you reliably go to dialysis? And then
Right.
there, because of AI, they have these auto suggested codes. It is amazing how many social determinants of health codes come up, and when you look at them, it kind of it can also help guide you to caring for this patient. Like
Mm-hmm.
somebody who, let's say you have an older patient who recently lost her husband. That could be, that could be a possible screening for depression. Or does this person exhibit, depression symptoms?
Mm-hmm.
Are they, is there, because of the disruption, I think is disruption of family or something.
Mm-hmm.
But also, is that a financial burden now because there's less money? So is this person non-compliant with their medicine because they've had a family disruption and they no longer have the money to buy their medication? So it is very, very, the social determinants of health are a very good indicator of how to care for someone clinically, and what can impact, and how these social determinants can impact their health.
Mm-hmm. Mm-hmm. And to your point, like even with non-compliance, clinicians oftentimes they're scratching their head like, oh my God, we told them to do A, B, and C. We've given them the prescriptions and the medication to do so. Why are they not doing? Well, this connects the dots, making sure they account. But the thing is, they have to, only because now there's a financial incentive, are they now like, oh yeah, let's do it, let's do it. Regardless of that, these things have been happening for decades. So why wouldn't you capturing that? And the codes have been there. It's not like, the homelessness code, I think expanding that particular category has been new. But the social determinants of health, these Z codes have been there for forever. And only because money is tied to it does it make sense to actually use them. It made sense to use them when you're trying to figure out, well, why is this patient non-compliant, and letting the other caregivers and clinicians know, well, this patient potentially has the ability to be non-compliant because they're homeless, or because they live in a food desert and they don't get fresh fruits and vegetables, because all of the things that can be part of that social determinants of health mix. So while I'm glad it's finally here, I'm like you, this should have been done a long time ago. A long time ago. And it really should it have to take money for you to do what's right? That's the other
But
thing.
but I also think that it was always done, but it just was never really accurately captured.
Correct. So maybe, some folks in their own they had their own way of saying or documenting that this may be the case in their notes, but then nobody was actually taking the additional step to code that and capturing it that way. So you may be right. Maybe that's
And
what. Let's
right,
give them the benefit of the doubt.
right, because there's always been, I mean, case management has always been involved with people who can't afford to buy their medicine, or
Yes.
and as a nurse, you see people who come in there all the time because they ran out of their medicine or they're not taking their medicine. But you got to dig a little deeper. Why aren't they taking their medicine?
Right.
So now that social determinants of health is a thing, and they're really talking about it and putting it on people's radars now, because people are capturing it. Now you have the data to support what has been going on for decades.
Yep. Yep. So I wanted to kind of think about some questions that came to my attention about making sure this is done in the right way. So one of the questions was, what ethical considerations should we be mindful of when collecting and using social determinants of health data? And it says, in light of the IPPS 2025 final rule, we must consider fairness in reporting. So with the change in severity designation for inadequate housing codes, we need to ensure all eligible patients are properly identified to avoid disparities in reimbursement. We also need to look out for the potential of overcoding, because it's going to be a thing. So we must be vigilant against any temptation to over-report housing instability for financial gain. You know how folks like to play with the church's money. And then look at patient dignity. While collecting this data is important for care and now reimbursement, we must do so in a way that respects patient dignity and doesn't stigmatize individuals. And we all know that's really a thing in the not only in the acute care setting, but in any type of healthcare setting, is providing the dignity to the patient. They already know they coming in a situation. Be mindful of that. Be mindful of that, and take care of them appropriately, regardless of that particular situation in which they're coming in. It says, how can we ensure that social determinants of health data collection doesn't lead to discrimination or bias in healthcare delivery? So the IPPS rule actually helps this, or addresses this, by recognizing the resource intensity. So by changing the severity designation, it acknowledges the real impact of housing instability on care complexity. It encourages comprehensive care. So this change incentivizes hospital to address housing issues as part of overall patient care, and then promotes equity, while it aligns with efforts to advance health equity by ensuring hospitals are fairly compensating for addressing the social determinants of health factors. What else? Let's see. What changes in coding and documentation practices are needed to better capture social determinants of health information? So again, the rule highlights the need for precise coding. So coders must be trained to accurately distinguish between the different types of housing instability. Comprehensive documentation, and that leads to the specificity. And so the documentation needs to specify specifically what has happened, so the coding can be captured accurately. Clinicians need to thoroughly document the housing status in patient records. regular audits to ensure that the new CC designations are being applied correctly and consistently, and then integration in EHR. So systems should be updated to flag these codes and prompt for additional SDOH information. I know, Mr. Jesse, you just mentioned that with the predictive code suggestions or suggestive coding, you've seen a lot of SDOH information come through. Hopefully, folks are now, well, I guess they should have been always paying attention, but hopefully they're paying attention and doing the additional work to dig in to make sure if they see the documentation that supports that they are also adding those particular code to the case.
Because I can tell, like from a CDI perspective, honestly, like most CDI only pay attention to something that's a CC or an MCC or is going to increase the SOI and the ROM. So we know that some of those codes will, like homelessness, and there's like I think there's another one that I see, but definitely that one. So anything that's going to increase, anything that's tied to money, they're going to get on it. Now the coder will code a lot more, but I try to pick up as much as I can that I can validate. But
so what training or skills do health information professionals need to develop to work effectively with social determinants of health data? So again, in response to this rule, professionals should develop updated coding knowledge. So they should have some familiarity with the new severity designations for housing instability codes, resource utilization analysis, so the skills to track and analyze how these social determinant of health factors impact hospital resource use, policy awareness, understanding how social determinants of health data ties into broader health equity initiatives and reimbursement policies. And you may even now start to see specific policies, institutional policies. So the organization may have specific policies that you also would need to be made aware of as well. And then ethical coding practices, the ability to navigate the balance between accurate coding and the potential financial incentives. Again, that's a tightrope right there where it's like, oh, well, just somebody just said homeless, slap this on, slap, there's a balance in making sure that the documentation is there, and folks won't all of a sudden see a gazillion homeless people in these hospitals because they're trying to get this incentive. So be mindful of that. Because of course, y'all know this is about the government. The government gonna be watching. They may not be watching this year or next year, but give it 3 to 5 years. They'll be watching and picking up on these as well. And then how can we improve patient engagement in providing accurate and comprehensive social determinants of health information? So we can explain the impact and help patients understand how accurate housing information can lead to better care and outcomes and resources for them. So if they would let us, because sometimes people like, I didn't come here for that. I came for you to fix whatever is ailing me. Whatever else is going on in my life is none of your business. And so, you have to, again, be compassionate and listen to your patient. And from what I've seen, especially as I've traveled into some large cities, especially those that have like the camps and all of those, it's a whole community and it's a whole culture, and you have to have some cultural sensitivity to the people that come from you from that's a different culture, and understanding that. And so, and the empathy that is required for that as well. And so as healthcare providers, particularly those frontline healthcare providers, you have to bring that to the forefront when caring for these types of patients. Also, assure non-discrimination. So clarify that this information won't be used to deny care, but to provide more comprehensive services. Connect to resources. Use this data collection as an opportunity to connect patients with housing assistance programs. And then training the staff, ensure all staff understand the importance of this data for both patient care and hospital operations. So those were just a couple of questions and things that, what this new rule will now help impact as it relates specifically for the housing instability social determinant of health codes. Mr. Jesse, did you have any?
I've seen firsthand how important the social determinants of health are, and it affects all settings. It's
Mm-hmm.
urban,
Mm-hmm.
suburban, rural.
Mm-hmm.
It Anybody can have social determinants of health that impact their health. So it really is something to be mindful of as somebody in HIM period, because you have to, with healthcare, you have to take care of the whole person,
Exactly.
not just why they're there, because there are a whole bunch of reasons why they're in the hospital, or why they're seeking care,
Right.
and it all can be explained a lot of times by their social determinants of health.
Yeah. Yeah. And finding ways to help them when they're not in the hospital, providing the appropriate resources that can help, to your point, take care of the whole person is essential in this day and time. We see it's a whole bunch of stuff going on in this world, and some that have been self-afflicted, some self-inflicted, and some not. It's just people were just victims of circumstance. Um, but nevertheless, they're here they are, and what can we do, and how can we care for them um, appropriately with dignity and compassion?
Because what I look, just as a side note, what
And
I
some of us that
really
already know we might be one paycheck
right.
away, but wait, keep it a buck. Some folks may be just one paycheck away from
And
experiencing this.
what I don't under or what I think needs to come back, because we used to have them everywhere. They need to bring back public hospitals,
They do.
because I think people got better care because they could get it.
Hmm.
And it just wasn't and that's the one thing that I give New York City credit for, because that's the only place that I know of, in at least like the Mid Atlantic region, that has public hospitals,
Hmm.
and they're pretty good. Matter of fact, like one of their most famous public hospitals is Bellevue, and that's one
Hmm.
of the hospitals that's designated when, if the president is injured in New York City, that's where they take him. And they
Hmm.
have some really shishi poo poo hospitals in New York City, but
Not she foo foo.
yes.
It's like, oh, can I stay here? It's like a spa.
Uh, Look, as Tiffany Haddish says, this is
This is
nice.
nice.
Look, but it's only nice if you got insurance.
Hey. And be like, this is not for you. Let me redirect you down the street over here to this little hospital where you can go.
Exactly.
Okay, let's see. Uh Carolyn wanted to know, do we know why they got rid of public hospitals?
Money.
Mm-hmm. Somebody asked, hi. Any ER doctors? They had a medical question. I don't know if somebody can answer. You can put your question out there and we can see if we can get an answer to it from someone who may be watching. She said, if you don't have insurance, you get put in the basement. Tanika also said budget cuts. Budget cuts. Yeah. And oftentimes, there medicine is a business. And so they're looking for how to get top dollar for the business that they're doing. So they're looking at, like, what are services that uh generate money, generate income. You see orthopedics, you see cancer care, you see um cardiac care, those are things that have high dollar price tags. And so a lot of, there'll be two hospitals sitting right next to each other telling everybody they got the best cancer care or the best cardiac care or whatever, because they're trying to generate that business, and they know that's a high price tag, that's a high dollar ticket item for the facility. So they're going after that. So your general care, your internal medicine, it's not as sexy, it's not as lucrative. You don't get, unless there's some kind of anomaly that walks through the door, or some new kind of thing that you would see primarily at, I guess, probably your academic medical institutions. But still, they like, we don't want that. That's not gonna generate a whole bunch of money. And so you're gonna be in and out, probably, in those instances.
And then and what people don't understand is you're still going to be impacted by it,
Mm-hmm.
because whether you are a public hospital or not, because I've also had patients who are older, and they're no longer able to take care of themselves. Like, they
Mm-hmm.
cannot be discharged to home.
Mm-hmm.
And can I tell you, those people can lay in a hospital for a month
Mm.
waiting to be placed, because they don't meet criteria for this facility, or
Yeah.
they have to be able to do meet this criteria in order to qualify for that facility.
Mm-hmm.
It and then I've even had people, while they're waiting, develop complications.
Mm.
So then it just becomes a very, very vicious cycle.
Right. And think about it, while you go to the hospital to get care for whatever ails you, you in a hospital with other sick people. Folks are sick. Stuff is floating. Everything, nosocomial infections are real. Like, stuff is out there. You don't want to be in that hospital. For real, for real.
I,
Oh.
I had a case where this woman was getting discharge instructions and aspirated and
Mm,
ended up on a ventilator. I mean, they were
mm,
getting ready to.
mm.
It's
Yeah,
it's just a
the longer you're in, the chances of something going left is there. So you don't know. No. But
yeah.
then if you're unfortunately have to figure out, because they can't let you go, especially if you need that kind of, they can't release you. Um and some of these, well, that's a whole other conversation. Some of these long-term care facilities, Lord Jesus, they need
Oh,
prayer. It's a mess. It's a whole mess. And then you have those that are, we talk about, this is not like country clubs exclusive. Like, you gotta have a key to get in. And that's unfortunate. There should be, I know there are certain criteria for nursing homes if you accept Medicaid and Medicare payments. So you have to have a certain number of beds, but those beds are usually gone, and they only have so many of those. They're not the majority. They are really, really the minority of beds. So they may have two or three Medicare, Medicaid beds, and unless something is happening, and there usually isn't a quick turnover for those particular beds. Those people will be there for a while, so then they can't accept any new ones. But then it's not like they're building long-term care facilities on a regular basis, right? They're not building.
exactly. And
So,
then and it's really sad, but people don't. I don't think a lot of people understand the
good morning, Tiana.
difference. The
Yeah.
difference in how you are, what kind of care you get when you're on Medicaid
Mm,
compared to. I mean, I've been in long term care facilities where people who are on Medicaid have the crank up beds. Like, they can't even push the button and raise themselves. Somebody has to literally go to the end of the bed, bend down, and crank it up to
mm,
elevate you. Then you have somebody across the hall. They have a darn near a remote control bed.
mm. It's sad.
It
It's sad.
is.
And you're right. They're very visible differences in, because again, we just had to make sure they had a bed. They didn't have to have the top of the line bed. They didn't have to have da 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 da. Folks know how to hold on to the dollars that they get and manage it. So yeah, we'll give them a crank up bed.
And the thing, I know we're getting at the top of the hour, but the thing that has always gotten me about just Medicaid and these people in these long-term care facilities, there are some people. Well, first of all, everybody is supposed to be allotted a certain amount of money per month for them to spend on whatever. And we know some people don't have the capacity to spend it, but I'm like, the facility should be made to do something for them. I mean, do something to spruce up their room. Buy them a clock that's a shape of a cat or something. I mean, do something. I mean, they do not. And so I'm like, what happens to that
They
money?
look institutionalized. It's a
Yes.
mess. Yeah.
And I'm like, they have money for this. Like, it does not have to be like this. You can get them a nice little pillow that says, I love you or something. I mean, something to make it make it seem like you really care.
That
Something.
you care, and provide them with some dignity, and let them feel, because it's their home for now. Make it feel home for them.
Because now, while we're going down that rabbit hole, I've said this before. The problem, it was Bill Clinton. When Bill Clinton came out with welfare to work, it ruined healthcare. Because what did people do? Because you couldn't, like back in the day, I've told this story before. The Commonwealth of Pennsylvania Department of Public Welfare paid for me to become a nurse. Bill Clinton stopped all that. So you now can only go into if you want to get a loan, you can get a loan and go anywhere. But if you want the state to pay for it, they'll pay for you to become a home health aide or a CNA. Nothing wrong with that. But if that's not what you want to do, you're not going to be good at it. And when I first started, people were CNAs because they wanted to be. And I remember this was back in the day, in the 90s. The CNAs used to go to the dollar store, buy them little gift bags, and they have their body wash and their gel and their this and that. I mean, and them those old people on their shower and bath days, they be sitting up in them chairs in the day room looking like Christmas hams.
Yeah.
They be greased up and hair slicked back, and little ribbons, and you could tell that they felt good. They be smiling.
When they look good, they feel
Yes.
good. They smell good. It makes a whole difference in their self-esteem. You know what I'm saying?
Exactly.
But I know he said Christmas hams though, for real.
Yeah. I mean, and then towards the end of me being in direct patient care, I would be like, if I can walk past a room and smell something that don't smell right, you should be able to walk past. So I'm telling you, I have done it. I've been like, no, me and you are going to come. We're going to give this person a bath right now. Well, I got something. No, right now, and we going to scrub them down and lotion
they can't
them
do
down.
it for themselves.
Exactly.
They need help. They're there for their care, and that's part of the care that they're paying you for.
Exactly.
It may be a couple of dollars because they may be on Medicare or Medicaid, but it's still dollars of care that they are paid for, and they should receive. But see, now I'm gonna be thinking about. I don't even eat meat. Y'all know that, but the Christmas hams, greasy as a Christmas ham, sir.
Well, you know
But
how
I
those
know
hams.
you are absolutely correct, and they just be happy, and yeah, and then because you have some folks that no one ever comes. They're the people there, the caregivers there. They become the family or the people that they look forward to seeing, and so.
And I've seen people. If everybody has rapport. Everybody latches on to somebody. I've seen patients. If a certain person is not working, they don't eat.
Here.
They just refuse.
They refuse. They don't come out. They won't come out the room. They won't socialize. They won't whatever. And they have considered that person their family, and that's who they're looking for to see. And so, we know on the opposite side, the folks need a day off, but they no, you're my person and you should be here every day. I should see you every day. Wow, wow, wow. Well, this was good information. I hope this was something that um helps you understand a little bit about the social determinants of health. When you start seeing all these homeless Z59 category codes all over the place, you know the reason why. Remember, there's always we talk about there's always a why behind all the things that you as a medical coder do. And this is providing you some of that why and that information. All right, all right. Let me see. Let me see. Do. Talk about our tea sippers. Yes, our tea sippers. So did you know by becoming a patron of ours or patron of ours, I'm gonna have to get this right because patron and Patreon is killing me. So you're joining a community of individuals who share a deep appreciation for the intricacies of healthcare revenue cycle. So here's what you can expect as a valued patron of a member of the Tea Sippers Patreon. How about that? Exclusive healthcare insights. So you can gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access, be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. Personalized support, enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. But the best part of it all is the community connection. Join a private community of healthcare professionals where you can network, share your experiences. And when I say the experiences are shared, it's shared, the real, it's shared. Um, and collaborate on finding solutions to common challenges. So while we talk about things that are happening, we don't stay in commiserate stage. We also think about, well, what can we do to help? How can we provide information to others so that um, things can change. We can be a conduit of change. And we do that as well. So by supporting us on Patreon, you're not only advancing your healthcare knowledge and career, but also contributing to the success of other like-minded healthcare professionals, health information professionals specifically. So let PRN, a resource, help empower healthcare professionals like you to thrive in their roles. So thank you for considering becoming a patron. Check out the link in the description of the video. Your support means the world to us, and we look forward to helping you excel in the world of health information. You can also check out patreon.com/Clarice Warner, the girl with the pearls. All right, all right. Let me get that down. All right, so thank you all again for joining the Saturday morning tea or checking out the replay. Let me ask, was the tea spilled today? Put your teacups in the comments. Put your teacups in the comments.
Absolutely.
If this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. And I'd just like to thank everybody who shares the video with others. I see the shares happening and I see the comments and all of the things. So we appreciate you and thank you so much for the work that you do to help get this information out to others. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave out, don't forget to hit the thumbs up or the like button. I see the teacups. I see the teacups. Yes. I love it. I love it. Yes. Okay. As you leave out, don't forget to hit the thumbs up or like button. And also check out the Coding Nurse channel on YouTube. He drops some gems. I'm sure he's gonna be dropping even more gems now that he has the additional time to do so. Stay tuned. Stay tuned. Some things will be dropping very, very soon. So this is Mr. Jesse. Do you have any final thoughts before we wrap up for today and go into our
No,
next session?
another great week, and I'm just glad to be part of this amazing platform.
And we're glad to have you. Definitely. So this has been a great session today. See you tea sippers at 10:15 a.m. That's where we have our meeting after the meeting. And the first part of the community connection sharing experiences begin. So again, thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care and have a great weekend.